Now, we have pretty much the time we've allotted in the schedule for questions. So I'm going to throw it open to questions. There's a couple of mics, roving mics around the room. If you want to ask a question, if you put up your hand, and when you do ask a question, could I ask you just to identify yourself in doing so, in posing the question, and then I'll lob it off to one of the experts on the panel here. So, anyone want to kick off?
My name is Ambrose McLaughlin, and I'm the chair of the Heartbeat Trust. And I think some of the speakers have already referred to the tsunami of chronic disease that's hitting health systems across the world. And I think one of the speakers put it eloquently when he said we're responding with an episodic system. So my question to the panel is, in particular, how is the private sector in Ireland and the insurance companies in Ireland and the health insurance system going to respond to the challenges that are going to face roughly 60% of the people of Ireland? 50% of the people will definitely be insured, but another 10% might be attracted to third-party funding if, in fact, we could see a response from organisations like the Bonds to the challenges of chronic disease management. Thank you very much.
Thank you, Ambrose. Nothing like a 6 marker to start off. Now, who wants to pick up that particular hand grenade?
I think I think the difficult thing for a state system is just as difficult for a private system, because we need to completely re-scramble the way in which we think about care. So we tend to think about prevention as in some way abstracted from healthcare. These are two separate things. And I think an insurance model is going to have to find a way of incentivizing better health-generating behavior all the way through the relationship with insurance. And in South Africa, Vitality, which is primarily aimed at sort of lower middle-class black people, actually has a relationship with greengrocers that can find out whether you're buying the cheap fruit that will go into your diet and therefore lessen your payments. So I think the possibility the private sector's got that I don't think the state has is to try and find ways of constructing incentives which are about long-term health-generating behaviour. And then even more significant, I think, for all of our systems is that when somebody has a long-term condition, the investment in better self-management of that long-term condition. One of the things I always say is if you have a long-term condition, you are awake for about 5,800 hours a year dealing with that long-term condition. If you're unlucky, you go and see a health expert for about 10 hours a year. And that means if we just concentrate on the 10 hours rather than the 5,800 hours, we are missing out on the main care activity that goes on, and we're in some way bypassing that. So investing in that better self-management of care transforms the value proposition for people with long-term conditions. And it's the only way we can construct a health system that my main carer for me when I get my long-term conditions will be me. And the more the NHS invests in my capacity to look after myself, the more likely is the NHS will survive. And that is a real change in the way in which we think about investing. I will be the workforce for my healthcare. And a professional will play a significant part in that, but not the main part in that. And I think this is a shift in real power about who's looking after who, which I think we all need to scramble our systems and think in an entirely different way.
I'd like to just add to that. We're one of 4 organizations in the United States that is has a health insurance company and a very large provider organization, and that in essence defines an integrated healthcare system. And what we have done is we've stopped looking at the insurance part of what we do as strictly a financing entity and as a healthcare entity. And it just underscores what's being said here, in that you can't think of insurance strictly as a financing entity. You have to think of it as a healthcare organization.
Ambrose, I think that was an excellent question. Some of us last night were treated to an after-dinner speech by Jim Dowdall, the Managing Director of Irish life health. And I think the real challenge and the invitation, particularly from the Private Hospital Association and the Bon Secours, is to work with the private health insurers to develop the sort of policies that are attractive to policyholders, subsequently our patients, and fundamentally restructure hospitals as the centre of all activity. We're blessed with a number of former colleagues here from the public health system, and in particular those who look after the acute hospitals. We've always known that there's by far the majority of activity relating to patients happens in primary care. We're the experts at a particular niche in the healthcare journey of patients in acute sector. There'll always be a place for that, but at the moment the reimbursement models, the funding flows, whatever language you want to use, and we heard some of that from Paul, at the moment we've got the telescope the wrong way around. And that point you made about the tsunami, we've known about that now, and today I'm hoping is the call to action to actually start doing something about it. And in your former role as Sec General, the importance here of policymakers in actually helping construct the future health service, I don't think can be understated.
While Mayo may be regarded, and rightly regarded, as a centre for tertiary or quaternary care, episodic care, we also have actually a very big primary practice. We are self-insured. So, for example, in Rochester, we have 30,000 employees, so they get their care at Mayo, as does their family, so there's 120,000. And we have, obviously, it's in our interest to make sure, first of all, that we keep our staff healthy, also to do it with in the most efficient way possible. So we are actually studying how best to do this through some innovative models. And in fact, as I mentioned, the Optum laboratories, all of this data is being fed in to this, into Optum labs, so that we can analyze outcomes. Because I think to really get the answers, this is something that has to be studied. The only way that you're going to advance is through research. And I think these are the tools that will allow us to get to the right answers. And once we get to the right answers, that we share this generously across not only the country, but indeed internationally. So I think we're all struggling to come up with the right answers, but as with most things, advancement requires that we actually study the issues and try what works, what doesn't work, and that is the way forward.
Thank you. Yes, we have a question here.
Good morning. Thank you very much indeed for the wonderful talks we've heard. My name is Dale Hacking. I'm the medical director at UPMC Whitfield, and I'm also South African, since that's been mentioned by one of our speakers. Mr. Corrigan's talks are very timely, and my own experiences, having come to open a centre and to work within the structure of the health system here. The question I'll ask the panel is going to be very contentious, I guess, but it needs to be asked. It seems to me that an organization like the NHS and the HSE here, as socialized medicine, and I'd say that the HSE is as dear to the Irish soul as the NHS is to the British soul. The size of these organizations becomes a problem, I think. The bureaucracy involved in providing care is probably as much to blame for the waiting lists and what's going on. And I would ask the question whether the role of central government should be more in regulating the quality of care and allowing the innovators to provide it within that quality frame. Is that something that the panel would agree with or not?
Thank you.
I agree. I think the NHS is the last big nationalised industry in England. and it has all the problems of a nationalised industry. One of the spurious facts that I was going around talking about in the year 2001 is that it's the third biggest organisation in the world after the People's Liberation Army and the Indian Railways, and actually these are not good organisations to follow. And size brings enormous problems. So one of the things that has happened in the reform programme, both of the governments I was involved in and the government since then, is an attempt to construct a system of organisations, interlocking organisations, rather than a single organisation. We've now got a national commissioning organisation that's separate from government. We have a national provider organisation that performance manages the providers that's separate from government. I'm on the board of the Care Quality Commission that does the inspections of that. So we have these interlocking organisations. But coming back to Michael's point about culture, the culture of the National Health Service is the public think it's a single organisation. So we have different organisations, but most of the behaviour of the leaders is as if it's a single organisation. So we've constructed a much better, I think, structure of interlocking organisations, which I think is better than it was a lot. But the behaviour and the behaviour expected by the public is, oh, I work for the NHS. People don't work for the NHS, they work for trusts. They work for different organisations, but the belief is it's still there. So we need to change the culture of the patients and the public as well as the culture of the organisation. But I think you're dead right. It is absolutely impossible. We have 1 million consultations every 36 hours, and the notion that you can run that from the top is crazy.
I previously worked as part of the HSE and a voluntary organisation, and as I said earlier, set up one of the first hospital groups. And just to echo some of Paul's points, we need to create the organisations, the interlocking organisations. When I was back in the NHS, we had a great phrase, the purchaser-provider split, and that the purchaser element, the commissioning function, if you like, would be responsible for policy. A separate organisation would be responsible for quality control. I think loosely, and Ambrose was a big architect of this at the time, that was the journey that we were on. The creation of hospital groups would ultimately lead to the creation of a commissioning function and to the disestablishment of the HSE. We've still got hospital groups and we've still got the HSE, and I think we've lost our way a bit, particularly in terms of the timing. The plan was a good plan, and I think we need to continue with it, not just within hospital groups, but also in the community health organisations, and create similar, but also avoiding some of the mistakes that the NHS made, those organisations and that commissioning function. And I think ultimately that will take the bureaucracy out, but more importantly, it will put patients at the centre of these local autonomous organisations who will have the ability to respond to their patient population, form partnerships with other organisations, and be much more fleet of foot. And my only criticism is we're taking much too long. We're already well past the date that we agreed to do that. And I hope we can get back on track and fulfill the original strategy that we set out.
I think that there was a study published in the New England Journal of Medicine about 2 years ago that looked at trust in the medical profession across 30 countries. The United States ranked close to the top as regards the trust that patients had based upon their most recent visit to their doctor. Yeah, we did very well. However, the United States, the trust in the profession was at the lower part. I think it was just ahead of Poland and a couple of other countries. And the criticism of the patients is that the medical profession seems to have ceded the governance of healthcare and coming up with solutions to those who have little familiarity with medicine and how it should be practiced. So I think there's plenty of blame to go around. I think that we haven't been training doctors to be active leaders within healthcare organizations, and that I think is reflected now in the changes in the curriculum in medical schools across the United States, including Mayo, that we're trying to better prepare doctors to actually understand the economics of medicine as well as the technology, so that they can actually be very active partners in the organizations in which they work. And I know, being a member of the board of RCSI, who's also looking at curricular changes, this is a key focus, so that we're turning out not only doctors who can take care of individual patients, but have a broader understanding of healthcare systems, the deficiencies, and are being appropriately prepared to actually partner in overcoming these difficulties.
Okay, I think we've time for one more question before the break. Anyone else want to? Yes, we've a...
Thank you very much. Dave Shanahan from Adagio Ventures. I'd like to thank the Bonds. I think it's been a great opening session, and I applaud the initiative. My own perspective, I've worked in the private sector, the independent health sector, I've worked with government, and one of the challenges I think we have in this country is that the policy and the public are not aligned, because the public are perhaps not sufficiently educated about the opportunities of health and the decisions that need to be made. And I just wonder, from the point of view of advocacy and media, every day you turn on the television, you'll hear one isolated story from health, which is giving a negative perception of the service. But I wonder if this can be the catalyst for something much bigger, where we finally get a 10-year plan for health from all of the stakeholders. And I'd like to hear the panel's thoughts on, and particularly Paul's thoughts, because what's happening here right now is following some of the challenges in the NHS, I would say. How do we galvanise a much wider coalition, and how do we develop a 10-year strategy which can bring the population with us? Because if they come with us, the politicians will follow and the policy will come after.
Thank you. Paul?
I was involved in doing that in the year 2000 with the NHS plan, and one of the driving ways to make that made that at all possible is there was almost a universal feeling the NHS was falling apart. So the public experienced it through waiting times, the staff experienced it through day-to-day activity. So we had an agreement inside and outside that something needed to be done, and getting people around a set of principles of that actually was a lot easier than all the Royal Colleges, all patient organisations. So I think it's possible if people really think they're on a burning platform, and that has to be with patient organisations. My last slide had the Richmond Group of Patients. If you look at Macmillan's website, which is a fantastic organisation around cancer, they're not going around saying it's all hopeless, but they are saying the model we've got needs to be transformed into more prevention, into dealing with survivorship. So we've got patient organisations willing to lead a different vision of change. The Age UK is probably the most progressive organisation in thinking about those long-term conditions we were talking about. So I think the only way we can do that, exactly as you put it, is to reach out to public and patient organisations and say, do you think this is working? And whilst, as I said, people love the NHS, most of the people experiencing it say, well, actually, there's some real problems here. And so the coalition has to come from outside into us, and then we need to say with them, these are the 5 things, that rather than 200 things, it's the way in which you all as business people construct your organisations around a series of simple priorities. What are the 5 or 6 things we're going to do over there? And I think nationally, Ireland and England could be in a position to do that, which doesn't involve very much of the politicians, but does involve the rest of civil society in saying this is what we need to do. Because it matters so much to everybody, And the level of anxiety, I think, in your country and my country about it is very high, and actually in the States as well.
Thank you, Paul. I'm going to draw the first session to a close to try and keep us in good shape time-wise. I want to thank the questioners, and I also would like to acknowledge and thank our speakers for a fantastic first session today. Thank you very much indeed.